Hello, everyone, and welcome to Best Practices for Treating Cardio-Renal Metabolic Disease. I am Lucia Novak, nurse practitioner, board certified in both adult health and advanced diabetes management, and I am joined today by my esteemed colleague, Leah Foster-Smith. Leah, would you like to just introduce yourself?
Sure, Lucia. Thanks so much. I'm Leah Foster-Smith. As she said, I am a board-certified family nurse practitioner and also certified as a nephrology practitioner. Happy to be with you all today.
Yes, indeed. So we have a lot of information to cover, so we're going to go ahead and get to it. And so our learning objectives is to identify patients at risk for type 2 diabetes, heart failure, and or chronic kidney disease who should be screened for cardio-renal metabolic diseases to reduce diagnostic delays, select the appropriate evidence-based SGLT2 inhibitors for treating patients, and integrate principles of multi-D care to diagnose as far as addressing treatment and ongoing management with patients with these disorders. So let's get going. We're going to get to the heart of the matter and talk about type 2 diabetes and atherosclerotic disease and heart failure. So we're going to start with Carl. I want you to keep him in mind as we progress through today's talk. He's 67 years old. He's had diabetes for 15 years and has the microvascular complication of diabetes-related peripheral neuropathy. He's got an A1C of 6.9 with his medications of metformin, pioglitazone, and glimepiride. Also included in his medical history, very important, he has established cardiovascular disease in the form of having had an MI about 11 years ago. He's also got chronic kidney disease stage 2A1, which means that his eGFR is above 60 at 65, and his UACR was normal or below 30 with 22 milligrams per grams creatinine. His hypertension seems to be appropriately addressed with losartan and amlodipine. He also has dyslipidemia with an LDL of 65 on SIMVA 40. And he has class 3 obesity, meaning his BMI is 41. So do you need to address anything given what you know about Carl today? Keep that in mind. What's obesity got to do with it? Well, this would not be a cardio-renal metabolic seminar if we didn't include the metabolic impact of obesity on the health of our patients with type 2 diabetes. Obesity has a lot to do with it. Nearly 42% of adults aged over 20 have the disease of obesity, meaning they have a BMI of at least 30 here in the United States. And so sadly and unfortunately, our children and adolescents are also impacted with just under 20% of them also having the disease of obesity. And in addition to that, obesity affects every organ system. This slide is not big enough to include the 236 plus diseases that are either directly associated or exacerbated by the disease of obesity. But we are going to focus on the 3 that I've circled: the type 2 diabetes, cardiovascular disease, and Leah will be talking more particularly about the nephropathy and how that is something we need to address as well. So if we look at just obesity and type 2 diabetes, 80 to 90% of people with diabetes will have comorbid obesity. And what the schematic on the right of the screen is showing you is how that obesity and the central adiposity, the fat deposition, the low-grade chronic inflammation, and how it impacts the pancreas with apoptosis, so cells are dying as far as those that make insulin, and there's reduced insulin secretion. It's affecting the muscle with increased insulin resistance and reduced glucose uptake. And of course, it's also affecting the liver with increased free fatty acids and insulin resistance, leading to increased glucose production during times where that should not be happening. And when you combine all of those together, they cause hyperglycemia, which eventually will lead to type 2 diabetes. What about obesity and atherosclerotic disease? Well, 44% of people with diabetes will have cardiovascular disease, and cardiovascular disease is rather large when we're talking about the different types. But 41.5% of those with diabetes will specifically have atherosclerotic cardiovascular disease. And they tend to be younger, and the disease is much more severe. And I mentioned that yesterday in the talk that I was doing when I was talking about GLP-1. Whoops. The schematic on the right is actually showing, again, the role of obesity, and it's really having to do with the inflammation that the obesity comes with or causes, and all of the cytokine release and some other things that happen that not only affect the heart on the inside, but also the structure of that heart. And we're seeing insulin resistance that leads to arteriosclerosis, hypertension, ventricular remodeling, heart failure, systolic and diastolic dysfunction. What about obesity and heart failure? Did you know that for every increase in BMI unit, so going from 30 to 31 or 31 to 32, there is an associated 5 to 7% increased risk in heart failure with each of those BMI units. So again, something we need to think about. 40 to 42% of people with heart failure will have type 2 diabetes. They tend to be younger as well as undiagnosed. But of the people with diabetes that have heart failure, the number is smaller. 14% of people with diabetes will have heart failure. What we do know is that usually by 5 years of having type 2 diabetes, 68% of those will develop left ventricular dysfunction. And so again, the schematic on the right of the screen is showing you how obesity impacts that. On the left of that schematic, it's talking about the chemical changes that occur, the sodium retention, again, that inflammation, right? On the right of the screen, it's the sheer weight, no pun intended, of the obesity and how it impacts the ability for the chest wall to be compliant, the pericardial restraint is increased, and then you add the buy one, get three free that we typically see with heart failure, hypertension, and diabetes. And now we can understand where obesity comes in and the comorbids of hypertension and diabetes with the development of heart failure. And so for those of you that are confused between preserved and reduced ejection heart failure, so when it's preserved, that means the heart cannot fill. So imagine trying to blow air into 3 balloons that are inserted into each other. It's really difficult to blow that balloon up. You get some air in there, and then when you deflate it, that air comes out. Well, ejection fraction is just that. It's a percentage of how much air is released. So while the heart cannot fill, the amount that's leaving that very stiff heart it appears to be normal. And so that's where we get preserved ejection fraction, although it's not a good ejection fraction. What we are probably more commonly associated with or understand is the reduced ejection fraction. We know that if we see an EF of less than 45, that person has reduced ejection fraction. What does that mean? Imagine now a balloon that you have blown to full expansion, and now you've deflated it. And that deflated balloon does not go back to its original state. It's floppy. There is still some air in there. And so this particular balloon doesn't have a lot of elasticity. And much like the heart, it's not able to pump. And so that's the difference between preserve and reduce. So hopefully the balloons will help keep that in mind. So what about obesity and chronic kidney disease? Again, this is Leah's superpower, so I'm not really going into it. But so that you know, 32% of all renal disease is directly related to obesity. And 34% of people with diabetes will have comorbid chronic kidney disease. And again, we're seeing where obesity comes in with that. And we're seeing, again, that inflammation, the insulin resistance, the adipokine release, all of that stuff, which eventually will lead to kidney failure in our patients. So now I'm going to try to combine the obesity, the type 2 diabetes, and the atherosclerotic disease. So if we start on the far right of your screen, we see the obesity with those adipocytes. Again, they are signaling incorrectly. They are letting off pro-inflammatory cytokines and other things like that, causing dyslipidemia in patients that have obesity, also causing issues with the liver, with the increased free fatty acids and problems with cholesterol management. All of that stuff leads to things that will develop plaque within the arterial wall and thrombosis. And then if we hit it from the left side of the screen in someone that has not only diabetes, but also hypertension, which is common, we see again that hyperinsulinemia and that increased inflammation and the advanced glycation end products of having that hyperglycemia creates a milieu that is very friendly to clot and thrombotic development. So that's kind of how we're tying the type 2 diabetes, the obesity, and the atherosclerotic cardiovascular disease. When we look at the guidelines, what do they tell you about cardiovascular disease and risk management? And this is from the American Diabetes Association. And again, when you have someone with type 2 diabetes that has at least one of the following: sclerotic disease, heart failure, diabetic kidney disease, or is at high risk for atherosclerotic disease, we cannot address these things in and of themselves. We have to look at the full patient and address these things concurrently. And then once we identify what is really the problem, what's going on, do they have heart failure? Is it chronic kidney disease? So is it a pump thing or is it a pipe thing? They have atherosclerotic disease and they have a high burden of atherosclerotic disease. Maybe it's peripheral arterial disease. It could be that they had an MI, they've had a stroke, something along those lines. And then once we identify what we need to do, we look at the drugs that are available. Amy covered a lot of that yesterday. We're going to go into a little bit more detail. All right, so the impact of native GLP-1 on cardio-renal metabolic risk. And again, this is our native GLP-1 that we secrete upon eating. And as you can see on this slide, it is a superpower that we all have. But for whatever reason, in people with diabetes, this superpower isn't working the way it's supposed to. But when it does, we see that it has an impact on protecting the heart, improving the vasculature, its effect on the brain, on the pancreas, on the gut, on the immune system. I tell you, when I say that this is a superpower, it really is. And it's fortunate for us in this day and time that we actually have drugs that will address this. We're going to be focusing on the heart and the vasculature impacts of the GLP-1, but again, it affects all of those things. So when we look at the cardiovascular outcomes trials that were done, keep in mind, these are done on every drug that comes to market for type 2 diabetes since 2008. So what we're seeing here are the GLP-1s that are currently available on the market, or at least have been studied. And the ones that you're seeing in the middle of the screen, they're in that darker blue. Those are the ones that have the FDA indication to be approved for at least secondary prevention, meaning that someone with established cardiovascular disease that has type 2 diabetes, the liraglutide, dulaglutide, and injectable semaglutide have been shown to reduce the risk of an additional event. When you look at dulaglutide, it's kind of special. It has both primary and secondary prevention listed, and that's because the way that that particular cardiovascular outcomes trial was designed, they included a large enough population of those with only risk factors and not established disease that they were able to study that population. It was powered enough, and therefore they have that dual primary and secondary prevention. What the rest of this is showing you, those that are in purple, so the Pioneer 6 on your far right, that's looking at oral semaglutide, that is ongoing, so we don't have that result yet. But the other two purple on the far left of the screen are their cardiovascular outcomes trial has been done. They have shown no harm, meaning that if patients take this medicine, they're not any worse off than someone with placebo as far as developing or experiencing a MACE event, but it doesn't come with any benefit to reduce that risk. So in summary, when we're looking at GLP-1 receptor agonists, we know that they are effective with glucose control. Again, Amy went into all of this in great detail yesterday. So we know that these are great drugs for glucose. We also now know, based on the slide I just showed you, that they really, especially the ones that have that FDA indication, which I've listed underneath that red square, about the reduced risk of major adverse cardiovascular events, and what we know about the GLP-1 receptor agonist class in general. While many of the ones that we use for diabetes are not indicated for weight loss, we do see that important benefit of addressing the comorbid overweight or obesity that many of our patients experience and need to have addressed. So now we're going to come back to Carl. I introduced him to you at the beginning. Again, he's 67. He's had type 2 for 15 years. A1C is 6.9, metformin, pio, and glimepiride. He's had a heart attack. He's got kidney disease, hypertension, dyslipidemia, and again, class 3 obesity. Do we need to address anything today? Are we happy with his A1C of 6.9? Maybe we need to think about how is he getting his A1C of 6.9? He's also got established cardiovascular disease, having had a heart attack 11 years ago. Are we adequately addressing that? He also has dyslipidemia with an LDL of 65 on Simba 40. According to the most recent guidelines, it is recommended that people with diabetes have an LDL of less than 55 if they have established disease. And the recommendations also state that they should be on a high potency, high intensity statin, and simvastatin 40 doesn't meet that cut either. So in addition, we also have to be concerned about the obesity. The obesity in and of itself is impacting his diabetes, his ASCVD, as well as his lipids, and we know eventually his kidneys. So we have a lot that needs to be addressed. Unfortunately, you have to choose one. So if you had to implement only one change, which would it be? Would you add a GLP-1 receptor agonist? Would you replace the simvastatin with rosuvastatin? Would you send him to a certified diabetes care and education specialist for medical nutrition therapy? Or would you add an SGLT2 inhibitor? I don't know if you all have the opportunity to actually answer these questions. So I will tell you that we're going to look at the guidelines. What do the guidelines say that we need to do? So according to the guidelines, if a person has established cardiovascular disease and type 2 diabetes, we need to be looking at that disease state. And it's regardless of what their baseline A1C is. So Carl's baseline A1C is 6.9. But are we doing anything to actively address his established cardiovascular disease? We are not, and we need to. So according to the guidelines, we actually want to look at the whole person. That's going to include additional risk factors, which includes his comorbid obesity. And we're going to be leaning toward a GLP-1 with proven cardiovascular disease benefit if he's not already on one. And those again include liraglutide, dulaglutide, or semaglutide subcutaneous. So if you had to implement only one change, you need to make that change give you the most bang for your buck. And adding a GLP-1 will not only address his glucose, but will simultaneously address his atherosclerotic disease, his obesity. It will also have a positive impact on his lipids, inflammation, etc. Again, those are the three agents that you could choose. I'm not saying that none of the others would not be something you would implement. In fact, many of us would have done all four of these things at one time, but I made you choose. So it wasn't really fair. So now we told Carl to come back for follow-up, but we don't see him for 6 months. And when he comes in for his 6-month follow-up, he tells us that he was admitted a month ago for shortness of breath and lower extremity edema, and his blood sugars were elevated in the 200s. When he went into the hospital, he actually had an A1C at the time of 7.9. And he was diagnosed with heart failure. So as a result, his pio was discontinued. They added glargine because his A1C was elevated 30 units. They continued the metformin. They continued the glimepiride, which was probably supposed to be discontinued, but we lost him to follow up. And he's still on the GLP-1. I just don't know what dose of his GLP-1 he is actually on. Thankfully, he saw an inpatient diabetes care and education specialist who started CGM on him. And again, he was started on treatment for his heart failure. The simvastatin was indeed replaced with rosuvastatin, and he's pending an appointment. But of concerning, and what we found from his CGM is he's below range. He's having hypoglycemia 5% of the time. 3% of the time he's less than 70, but 2% of the time he's actually less than 54. And it seems to be happening most often before dinner. So now we need to think, what are we going to address with him today? His heart failure management or the hypoglycemia. So we need to think about the hypoglycemia, because when you combine that with atherosclerotic disease, we have a quite lethal combination of events that could happen. So if we look to the left of the screen, it's actually talking about the mechanisms of sudden cardiac death due to insulin-induced hypoglycemia. And insulin-induced could also be secondary to a sulfonylurea because of the increased insulin secretion that those drugs cause. So directly, the hypoglycemia will cause low potassium, a rise in epinephrine, norepinephrine, and the elongation of the QT interval. And the indirect effects of the hypoglycemia are central nervous system. So how the central nervous system innervates the heart, the tachycardia, the arrhythmias, the third-degree heart block that can result eventually bradycardia and sudden death. On the right of the screen, it's actually showing you what happens based on where that glucose might be. So again, when the glucose is as low as 70, we can start to see changes in potassium, and we see that QT prolongation, and premature arterial contractions can start to occur. As the blood sugar drops, we start to see even more things happening. But let's say he doesn't go down to less than 15. We just have glucoses that are less than 70. And if it's for a prolonged period of time, is when we start to see the epinephrine peaking, the QT prolongation occurs, and that's where we start to see that chance of sudden death. So if anything else, we have to address that. What about the SGLT2 inhibitors? Because our guidelines bring that up quite a bit. And I mentioned that when you're looking at atherosclerotic disease, that's pipes and that's GLP-1. But when you're looking at heart failure and chronic kidney disease, that's pumps. And that's where the SGLT2 inhibitors really shine. And on the right of the screen, it's showing just the mechanism of action of those SGLT2 inhibitors in the kidney, how they block the SGLT2 receptor, leading to diuresis, natriuresis, glucosuria, which is how they help with the glucose management. And then on the right of the screen is showing how the SGLT2 inhibitors go beyond that. So we know that they're going to improve glucose, but we do see an improvement in blood pressure. They lose some weight because they're peeing out calories. They have improvement in kidney function and myocardial metabolism. And all of that together leads to reduced inflammation, reduced remodeling, reduced adipokines, and all of those things that can eventually cause heart failure. So we see how the SGLT2s actually can reduce the risk for heart failure in our patients. And this slide is showing a summary of all the SGLT2s, except for one of them, that we currently have. And as you can see, all of them have shown a tremendous statistically significant reduction in heart failure, but not all of them have heart failure on their labeling. So it's important to understand which ones do and which ones don't. And so the three that have heart failure listed would be dapagliflozin, which actually encompasses all reduced, preserved, as well as mildly reduced heart failure. We have sotagliflozin, which is not used for diabetes management, is specific for heart failure, whether or not you have diabetes. The same thing is true for DAPA. And canagliflozin also has heart failure in its labeling, but it is specific to people who have type 2 diabetes and chronic kidney disease that would be at risk. So we have some drugs that are available. Knowing which one to pick is going to be important. Good news is that you don't have to worry, is it reduced or preserved heart failure, because we have drugs that can address all of it, like the DAPA and the sotagliflozin, and then empagliflozin will address that as well. So 6 months later, again, so now he's before us, what do we need to do with him? He's having hypoglycemia. He has comorbid heart failure. He has obesity. What are we going to do? Well, first, we're going to remove that the glimepiride, because sulfonylurea and insulin together is a nightmare waiting to happen. We're also going to discontinue his insulin because we have other plans for him, and he really doesn't need something that's going to cause additional weight gain as well as put him at risk for hypoglycemia. His A1C was 7.9. It's probably better now because he's been off. So we're going to maximize his GLP-1. Whatever one he's on, we're going to escalate that dose according to label, making sure that he tolerates it, but get him to the maximal dose of whatever he's on. We'll continue the metformin. It's not going to hurt him. We know that it's weight neutral in people with diabetes, but because of that heart failure, we need to think about managing his diabetes without increasing his risk for hypoglycemia, addressing the weight, but also that heart failure. And that's where we can then add the DAPA, the soda, or the empagliflozins. And with that, I'm going to turn it over to Leah.
All right. Great job, Lucia. Thank you so much for such a great presentation. So in our presentation, and we're going to focus on that chronic disease triangle. That is going to be chronic kidney disease, diabetes, and that cardiovascular health. So let's jump in. So let's start with some kidney disease statistics. Of course, being a nephrology nurse practitioner here, we want to make sure we know where this is coming from. So we get our data from the U.S. Renal Data System. We've had this going since 1988. So stats are pretty consistent. What we're seeing, though, is worsening of the state of the union in the United States. So we're up to 1 in 7 American adults having chronic kidney disease. It's the 9th leading cause of death in America. We've got an estimated 35.5 million people who currently have chronic kidney disease, and 1 in 3 U.S. adults are at risk of chronic kidney disease. That's upwards of 80 million. So it doesn't matter where you practice. These patients are right where you are. Approximately 90% of patients who have kidney disease don't even know they have it, guys. That's a big deal. So accounts for 17.4 deaths out of 100,000. And for those that go on to needing dialytic therapy, the 5-year survival rate's about 35%. So we do have patients who live longer than that on dialysis, that is the real stat. So screening is of the importance. Who has chronic kidney disease? So we can find those patients who do not realize that they have it. So this is where we all come into play. So again, that kidney disease awareness remains low. When we look across the entire world, only about 6% of the general population and 10% of the high-risk population, again, know their CKD status. Again, that's really important to remember. And there's currently no evidence-based guidelines regarding the frequency of screening of people in that generalized category of chronic kidney disease. Also kind of disturbing. But in the diabetic world, the American Diabetes Association and our kidney-related guidelines are called KDIGO, Kidney Disease Improving Global Outcomes, both recommend annual screening of patients who have diabetes to see if they're getting. Do have recommendations there. So what happens? How are we going to know? We're going to need to do testing. So initial testing, we need to look at kidney markers. So the first kidney marker we're going to look at is that serum creatinine, and that serum creatinine-based eGFR. We're going to talk about the different formulas that are out there coming up. But then you may need some additional testing for accuracy, and that's where the serum cystatin C comes in. I personally use this if I have a potential concern with their muscle mass and if there's going to be effect there. I don't do it always, but it's there for us. We also have a cystatin C-based GFR that you can also use if that is available in your lab. 24-hour urines are always there. We do these a lot in nephrology just to verify and quantify. So there's one for creatinine clearance. Again, creatinine clearance equals kidney function equals GFR. All those terms are equal. And then there can be errors in that cystatin-based eGFR. So that's those low muscle mass patients, those very high levels of inflammation, right? High catabolic states and exogenous steroid use. And then we need to screen for protein loss, albumin being the primary protein. But please do not remember, it's not the only protein that people lose, but it's the primary one that we're screening, and that is the one that they lose in diabetes. And that is going to be that spot random test, that urine albumin to creatinine ratio is what we're going to use. Now, I do want to kind of educate for a moment on which EGFR calculations that we're supposed to be using and what age. Now, in the past, we've used the MDRD, Modifications of Diet and Renal Disease calculation that came out in 1994. We also were using a 2009 formula that was called CKD-EPI, which was Chronic Kidney Disease Epidemiology Collaboration. But as we were approaching into 2020, we in the nephrology community were worried about racial disparities in our formulas. And the National Kidney Foundation and the American Society of Nephrology got together and formed a task force. I actually sat in on part of that as a scientific advisory member in NKF. And ultimately, what came out of our meetings and task force creation is that we had publications in both Journal of American Society of Nephrology and the American Journal of Kidney Disease that we need to get the race-based calculations out of the formulations. So the recommendation that's out there in the guidelines since 2021 is to use the updated CKD-EPI formula, that is from 2021, remove the race, or serum cystatin C. So these are all the formulas that are out there. Many of us have these on our phones. The old Cockcroft vault is fine. It's a weight-based. It's just not in the current recommendation. Is it MDRD? Is because if it's coming back on your labs and you see two GFRs and one says African-American or non-African-American, it's not the recommended ratio. Even in referral for transplantation, units will not accept any MDRDs because there is a disparity. So please make sure if that's not happening in your communities that you see if you can get it switched. The next thing we need to do, how do we diagnose a chronic disease state with the kidneys? Well, we have to establish a history of chronicity. Chronicity comes when things are changing with 3 months or more of data indicating disease efforts. Otherwise, it's an acute kidney process or subacute. Technically, AKI is usually under X number of hours, whereas subacute is going to be under that 3-month mark. So we're looking at the kidney markers. Have we seen changes in creatinine and GFR for over 3 months? Is there signs of structural issues going on? And we see that through protein loss, so proteinuria, albuminuria. Or we're doing a scan, renal ultrasound, CT scan, where we see the kidneys. And do we see kidney-related changes? So what does that mean? Size. What is the normal size of the kidney? 10 to 12 centimeters. Anything under 10 means small kidneys. And if they're bilateral, that's an indication of chronic disease. Again, as we lose our nephrons, our kidney functions, we will see the kidneys going smaller in size. We will also see thinning of the portal area. You can find other things, fibrosis, atrophy, other related comorbidities, as even Lucia said, on diabetes, history of obesity, hypertension, some of our big causes of chronic kidney disease, and then looking at that 3-month mark. So nomenclature is very important to make sure we're up to date on how we are classifying and documenting what their kidney disease state is. What is normal kidney function? It is an eGFR of 120 milliliters a minute, plus or minus about 10. Now, I doubt most of you will see a 120 on your labs either, but that is definition of normal. So stage 1 is now, all the stages have a G in front of them. So G1 is going to be a GFR greater than or equal to 90. 2 is probably where most of us are getting into it, going, something's happening here with my patient. So that's a GFR of 60 to 89. And then stage 3 has been broken out by KDIGO as of like 2012 into 2 stages. So 3A, 45 to 59. 3B is 44 to 30. Stage 4, now I think most of us are going to be aware that something's going on by this stage, I hope. 15 to 29, and the eGFR of under 15 is stage 5, and they're 5 till we start dialytic therapy, and then they transition to ESKD. Most of them are at GFR of less than 10. Then we have categorizing on loss of albuminuria. So the categories A1 is normal protein loss. Albumin under 30 is considered normal. A2 is a UACR 30 to 300, and that is technically microalbuminuria by definition. And then the A3 is that going to be any patient that has more than 300 milligrams in a day of protein loss. So again, combining that What is the definition? We've got chronicity of more than 3 months is the cause. We do want to find the cause of their kidney dysfunction, even if it's a presumed clinical diagnosis like diabetic kidney disease. Some patients will end up needing a kidney biopsy to figure out what's going on. We want to stage them correctly, and then we want to see how much albuminuria they have. And this, again, came out of KDIGO. Now, one is very important. The American Diabetes Association has lined up with KDIGO, so we're seeing the recommendations come together between these two organizations. And again, as a reminder, any patient who has established chronic kidney disease, again, with diabetes, we want to be doing a UACR minimally once a year. Higher recommendation is quarterly, so 4 times a year. Again, that would probably be my suggestion as well. So when we look at the heat map, if any of you have not been familiar with the KDIGO heat map, here it is. Now, the ADA took this heat map and has added in better information to help us, especially in the non-nephrology community, know what to do with the data that we're receiving. So, of course, when you look down the y-axis, it's giving us the CKD staging. And, of course, as we go down that staging, even with no proteinuria, A1, of course, as we get into stage 3A and 3B, we need to be treating. And as we get into stage 4 and 5, they should be referred to nephrology, even though I would tell you to refer to me way sooner than that. But with no proteinuria, you can hold on to them. When we get into any protein loss, so even 30 milligrams or more, you're going to see we should be treating in stage 1 and 2, which means you need to be aware that they've got chronic kidney disease. And then we start treating heavier at stage 3A and referring to nephrology at stage 3B. And then with proteinuria above 300 milligrams, their rate of progression starts as soon as that's happening. What their stage is, you need to be heavily treating and referring to nephrology with 300 milligrams or more based on this recommendation. So another thing I want, sometimes this is lost in the heat map, and maybe being a nephrology MP, I just want to share this with you all. But, normal protein is under 30. What we classify microalbuminuria is 30 to about 299. What I call macroalbuminuria is 300 to 999. And we truly call proteinuric patients about 1 gram to about 3.5 grams of protein loss. And then what about those nephrotic syndrome patients? You may have heard of these in the past. So first of all, you have to classify what is nephrotic range proteinuria, right? 8 grams to 3.5 grams protein loss. And then the diagnosis of nephrotic syndrome is nephrotic range proteinuria with 3 other qualifying factors: edema, low serum albumin, and hyperlipidemia. And then with significant protein loss, typically above 8 to 9 grams, there is high risk of clotting showing up as DVTs and PEs. So proteinuria. So in proteinuric patients and in these diabetic kidney disease patients, it is very important that we are starting to treat this disease process. So we all have a love affair, I think, early on with RAS inhibitors. And in nephrology, that love affair goes deep because these agents are renoprotective. Why are they antiproteinuric? So I want you to go back in your pathophysiology brain, going back to your individual nephron. And what did you see at the beginning of that nephron? It's a glomerulus. We have a little vessel that comes into it. It's called the afferent arteriole, and out of it is the efferent. In a lot of disease states, specifically diabetes, what happens at that glomerulus? The afferent dilates. So you got lots of flow, but the efferent constricts. What does that mean? There's a dam up effect that happens. Blood's going in, but not out so well. So if you do a CT or ultrasound early on in a diabetic patient, and in their CKD stage 1 or 2, you're going to actually see enlarged kidneys because the state is hyperinfiltrated. Your glomerulus are fat, and when they become fat and all that, where does the protein go? It's building up, and it squeezes down through the glomerular basement membrane and ends up in the urine. So what do we want to do? We want to dilate. So ACE inhibitors dilate. They dilate veins and arteries, and if we dilate afferent and efferent arteriole, it changes this landscape. Pathophysiologically, we'll drop the GFR a little. What's a little? Anything under 30% is not concerning. Now, again, these agents also help with heart failure patients with reductions in preload and afterload, and again, they're an antihypertensive agent as they dilate vessels. So I want to start with Elizabeth. She's going to be our case patient. So Elizabeth is a 6-year-old female who has come in with complaints of lower extremity edema. If you look at her medical history, she's been a type 2 diabetic for 12 years, also with known diabetic retinopathy. Hypertension for about the last 5, it's just at 140 to 155. She is dyslipidemic and has obesity class 1. I see some internet. Okay, hold on. My internet showed unstable. Blood pressure on the high side here, 148 over 80, 145 over 82, BMI above average at 32, some pedal edema, and of course, increased adiposity and waist circumference. She's on metformin, lisinopril, and atorvastatin. And as we looked at her labs, her A1C is a little high at 7.8. She definitely has a positive UACR. You see what the number is? 540. So she's in that macroalbuminuria range. A3 on the KDIGO heat map. Her serum creatinine's 1.8, her 35. She's also got some anemia, deficiency. Her potassium is okay. Her bicarb is 21. So we're going to see what all that means here in a moment. So my first question to you is, does Elizabeth have CKD? Does she have diabetic kidney disease? So if we look through the history here, with type 2 diabetes for 12 years, and we're going to look at this stat coming up in a minute, with microvascular disease showing up in her eyes, and we see some changes there in her creatinine and GFR, and we have evidence of proteinuria, she's a presumed diabetic kidney disease patient. We need to do a little bit more, but yes, we are there. Now, again, what would be her stage? Now, remember we saw stage G1, G2, 3A, 3B, and 4. She's a GFR of 30. 3B, right? That is our stage based very numbers. So as we look at Elizabeth, again, that diabetic retinopathy is very important as we're doing history. When you start getting microvascular disease in one area, it's happening in the other. By the way, it's one of the factors we use in the diagnosis. Again, you see the positive there that I pointed out on the physical exam, things that we're going to need to potentially address. And then we're looking at those labs. Now, I'm definitely worried about the UACR being high. That's going to impact progression. We need to be working on that with our treatment options. So that is macroalbuminuria. Again, diabetes, again, where it needs to be on the A1C. Her blood pressure is not where it needs to be. She's even her functioning as well with some potential anemia, some acidosis, some mineral bone disease that comes with chronic kidney disease, vitamin D. Okay. And how does all come together? So first of all, diabetic kidney disease is a clinical, unless you have a biopsy proven, and most diabetics are not biopsy, we go through with a presumed clinical diagnosis. And not all diabetics will develop diabetic kidney disease. 20 to 40% of them will, but we need to be screening, right? So again, what we see, type 1 diabetics is about that 10-year mark, 5 to 15 in general. Elizabeth was at 12 years, but she was a type 2. Type 2s, we can see even at the time of diagnosis, because some of them had been diabetics for a while. They just weren't diagnosed. At the time, when we think about CKD and why this is important as diabetic kidney disease patients is because they can and will progress to ESKD, and they're actually the number one diagnosis that ends up as ESKD, and that is US and worldwide. And the other thing to remember about these patients is there's high risk of cardiovascular changes, high healthcare costs. We're the number one user of Medicare, especially as they get into ESKD. And the number one cause of death in all CKD patients, regardless of etiology, cardiovascular. So it's all intertwined here. So if we look at screening here with our standards of care from the ADA, in that your anyway should be assessed in type 1 diabetics at greater than or 5 years at the time of diagnosis, and type 2 diabetes at the time of diagnosis, regardless of treatment. And if you're seeing a patient who's already in your clinic with chronic kidney disease, you should be screening for and monitoring their level of kidney disease with those markers, with UACRs, 1 to 4 times a year. What about blood pressure in these diabetic kidney disease patients? So if we see them together and we see that in Elizabeth, that is a strong risk factor for their chronic disease. In other words, pressure. See, the lines, it pressure 30 over 80 in this patient. I will say that KDIGO is pretty much in line with ADA here, except for they, in our most recent updates in 2022, is they want us to, which way are we measuring the blood pressure? Is it standardized or is it routine casual? If it's standardized, they want us to push them closer to 120 over 80. If it's routine casual, under 130 over 80. So a little difference there in those recommendations. RAS inhibitors remain first line in these patients. And then remembering that the trials with SGLT2 inhibitors and MRAs, we had that max dose tolerated of RAS inhibitors as inclusion criteria. So that has been the order of things that we are also doing. So I want to point out, because sometimes we go straight to pharmacy, but lifestyle factors are also very impactful in this patient population, and it's all over the guidelines. It's been in our hypertensive guidelines, it's in our diabetic guidelines, and now KDIGO came with a generalized CKD guideline. It got launched in 2024, and it's there as well. First of all, physical activity, 150 minutes a week for these patients. Dietary changes, so protein amounts. In a chronic kidney disease patient who has diabetes, the recommendation is 0.6 to 0. Day. If they're a non-diabetic, a little lower, 0.56. Also, patient hemodialysis, it's one separate for importance and why we need to help us, right? And then sodium intake under 2 grams a day. I'm sure that's standard in a lot of things and patients as well. Up for 20, absolute avoidance of tobacco products. Again, another risk factor, just like obesity. Tobacco alone, both of those can lead to multiple glomerulopathies, just like Lucia said about the obesity. Now, this is coming out of the ADA, and again, they've got the and the KDIGO together. There's kind of a combined here. They both have the same thing in their guidelines. So we've got our lifestyle at the beginning, which we just referred, and then we're looking at those therapies. So metformin, SGLT2 inhibitor right there at the top. And then, of course, if we're getting issues with metformin or if we need to discontinue it, so in kidney patients in 45 absolute at 30 because lactic acidosis, that had a lot. Didn't change your own metformin. Happens all the time, by the way, in our amnia. If so, then we're moving on to the GLP-1. And then for pressure management, we've got our RAS inhibitors, and then we could do non-steroidal MRAs if they're ACRs above the or dihydropyridines and or diuretics can be a part of it. And then statin therapy, very important in this population as well. I do want to make one statement here. CKD patients and ESKD patients completely different with management of cholesterol therapy. Can we initiate in CKD patients? Yes, we use the normal guidelines. There were 3 landmark studies that ended up changing the KDIGO guidelines in regards to naive ESKD patients who have never been on statin therapies. You are not supposed to initiate. No evidence-based 3 studies. We can talk about that in the Q&A if you don't know much about that. All right, next. So does SGLT2 inhibitor treatment improve outcomes in patients with CKD and albuminuria? The answer is absolutely. So we've got the heart failure impact CKD like upwards of 50%. Any day not on dialysis is a good day. Please give me these agents if I develop CKD. So we know multiple impacts here. And it is class effects that we are seeing here on that. So when do we initiate SGLT2 inhibitors? Well, at least for now, I think it could change, but right now the eligibility is an eGFR under 20. Are we initiating below 20 in nephrology? You might. Just not sure of the impact. Well, could interact incorrectly and make us go to a little AKI and on to ESKD. So initiation, we really want to see above 20, but we continue these agents until they start dialytic therapy or get transplanted. So we don't stop them at 20. We're continuing them Unless they get an AKI or something like that's going on, we are continuing them. Now, contraindications, I'm sure you are all aware of these things to think about. Is there a genitourinary issue going on? Is there infection risk? Frequent DKA, foot ulcers. Again, where is their immunocompromised status at? And then I don't want you to forget, just like RAS inhibitors, if etc., these can end up causing AKIs. We have to be very diligent to know these effects. They're great benefits, but you've got to watch what's going on with the diuresis that can occur here too. So really make sure you're watching this with multiple agents combined. And then follow up here, very similar to RAS inhibitors. If you're going to start an SGLT2 inhibitor, recommendations bringing back 1 to 4 weeks. We're 7 to 10 days in our office, by the way. We're looking at volume. We're looking at a renal panel. So we're looking at the sodium. We're looking at the creatinine. We're looking at all those things to make sure we're doing okay. And we do check blood pressures. Again, SGLT2 inhibitors have some natriuresis as well as diuresis, and we can see the blood pressure go down. So what about sick day rules in CKD? So this is very important. And, there's a big list that we all have in medicines. I hope you have your little sheets that you give out to your patients. But educating and informing patients about sick day meds are going to be very important. Again, dehydrating illnesses can lead to AKI. So even if they're chronic kidney disease and they've been 3B for a good while, they can get an acute or chronic episode. So we want to think about those sick day meds. So I don't know if you've heard of SAD meds, but this helps us remember some of those important ureas, ACE inhibitors, diuretics. Most of us are not using direct renin inhibitors, but I have it on there. Metformin, angiotensin receptor blockers, NSAIDs, and of course, SGLT2 inhibitors. Now, it's not that they go off of these forever, but we need to educate them about calling us and holding in that dehydrating GI type of illness. Very important to avoid AKIs, especially in the kidney patient. So let's look at Elizabeth here. So let's go back. Metformin, lisinopril, orvastatin as a remembrance. These are the labs. No change here. Just bringing it back forward for all of us. And now I have a few questions for you. What adjustments would you recommend? Would it be lifestyle modifications? Would it be medication adjustments? What about more labs on her? How about any diagnostics? What about, let's see what I might recommend. In lifestyle, well, we've got the sodium diet under 2 grams, 150 minutes of exercise weekly, and goals to get that BMI under 25. Medication adjustments. She's acidotic. I think she needs to come off the metformin. Now, what you add next here can be up to you. I added on semaglutide, but you could change it to something else. But again, following labs and seeing how she's doing, and it's time for nephrology, right? Her GFR is going down. She's got significant proteinuria. It's time. So what does that mean? What are some other ideas here when you're thinking, when do I refer to you guys or refer to me per se? So what is their cause of CKD? If it's hereditary issues going on, polycystic kidney disease, etc., they need to come us so we can figure out what's going on and get measures in place. If they have a GFR under 60, you need to heavily consider getting them over to us and any proteinuria. Also, what about hematuria with any CKD? Absolutely. This could indicate a glomerular nephropathy, and we need to get that looked at. Is there any active urinary sediment if you've done a urine microscopy? What about AKI and then electrolyte disorders we manage from potassium to sodium, etc.? Now, what I've put here in this bottom list, sometimes either you're not referring early enough or maybe in your area, nephrology's got a 4 to 6 month new patient wait. You have to understand this is a list of all things that we will be treating in CKD patients. And if they're staying with you and they're not with us yet, you need to consider CKD progression, treating that hypertension, treating that protein. Is there anemia? Is there metabolic acidosis? Is there mineral bone disease? What's going on with their electrolytes? What's going on with volume? This way you need nephrology, right? This whole thing. Avoidance of NSAID. If they're stage 4, replacement therapy. And when do you transplant? You transplanted at a GFR of 20. Yep. Okay. And that's important as well. So it's a multidisciplinary care team model approach here. So obviously in these CKD patients, we need nephrology, we need internal medicine primary care. For diabetics, we need endocrinology. I think for all of them, we need cardiology. Most of them have something going on. Transplant surgeons, vascular surgeons, as we are preparing in stage 4. And then other people that are important as well. Palliative care, I believe in that in late stage 4, stage 5, they're getting ready to approach end stage status. Many interventions, I mentioned this on the last slide. I'm going to add here at the bottom, MedRec. Renal drug dosing, GFR under 60, many drugs need to be adjusted. Please look up drugs on these patients. And vaccine programs, they are all immunocompromised. They need to be updated on their vaccines. And outcomes, and CKD. The last one, optimal starts on dialysis, means getting them to nephrology, getting them prepared for dialytic therapy, and avoiding use of central venous catheters, high risk of mortality there. So that takes some prep to get vascular access placement done before they need dialysis. So Elizabeth is now coming to see me. She's in the office and you have referred her to me. So I've got the same labs that we've all seen from our last visit, and I added a renal ultrasound. Before she saw me, I told the ultrasonographer coming in the door, I want one. Now, man, her kidneys are small. They're under 10 centimeters, both left and right kidney. I also see that she's got increased echogenicity. This is a nonspecific kidney finding that shows diffuse kidney disease, and she's got some thinning in her renal cortex. So I'm seeing chronic disease as well. So I'm stating chronic kidney disease stage 3B, secondary to diabetic kidney disease. I'm also adding on that macroalbuminuria diagnosis with that UACR of 540. I'm going to look at her anemia. I don't know if it's CKD yet. We've got to do some eval there. She's definitely got acidosis, and she's definitely got vitamin D deficiency just off the labs. Now, medication-wise, I would like an SGLT2 inhibitor on her. I need to address her vitamin D deficiency, and I chose cholecalciferol, and I need to treat the acidosis. And I'll tell you why here in a moment. And then I want to focus. I want her to understand that she's got chronic kidney disease. That's why she's here to see me. I want her to avoid NSAIDs. I want to monitor her labs closely, and I want to expand my labs so I can evaluate anemia and her mineral bone disease as well, and just do a little bit more on urines. So I just want to point this out. Many of you may not know this. There were 2 studies in 2009 and 2019 that showed that when we treat metabolic acidosis and chronic kidney disease with alkali therapy, aka sodium bicarbonate, it also delays progression. It also lowers all-cause mortality. So if you see sodium bicarbonate coming out of nephrology, understand its importance. So at her second visit with me, labs are getting a little better. Her GFR is now up to 38. We're seeing now in that expanded lab, her hemoglobin is still low, but you see her MCV 74. She's microcytic anemia. I need to get some iron. She probably has iron deficiency going on, most likely. Potassium's up just a smidge. Bicarb's better. Phosphorus is a little high at 4.8 for a CKD3B patient. Really needs to be under 4. Her PTH is elevated. She's got some secondary hyperparathyroidism, and we've gotten her vitamin D at least above 30. I did a microscopy. She's got some waxy cast. If you ever see this, also you can see her getting a little better with that addition of SGLT2 inhibitor so far. And I've added on a mineral bone disease diagnosis here. So what did I add on as nephrology? I also added on some iron. I added on calcitriol, a vitamin D analog, to treat that PTH level. That's at 200. That's a little too high at her stage. And I'm adding on a little bit of a diuretic because she's still got pedal edema. And then I'm going to do some referrals. I send to dietitian it does not. They need dietitian. They need to be on a low phosphorus diet and stop churning that kidney so high. I might need to consider a phosphorus binder or a potassium binder in the future. Don't know much about those. We can talk about those in the Q&A as well. I know I've got a few minutes left, but we had an old Kexalate that's been on the market for a long time. Beltasa, Locella have been on the market in the last few years. And those can be add-on agents so they can stay on the RAS inhibitor longer. And so we're using those a lot in nephrology. If you guys are not, something you may want to look at. In regards to phosphorus being elevated, that is for development of cardiovascular disease in kidney patients. So getting the PTH down and getting the phosphorus down, key in that long continuum that we're going to be on and to help reduce cardiovascular impact. So another big thing. And with a 3B patient, we're minimally going to see them every 3 months in nephrology. So as a recap here, as we are pulling together diagnosis of chronic disease in the kidney, we want to see 3 months of longer of disease presence, proteinuria, kidney marker changes, etc. If you did a urine microscopy and you saw waxy cast, it's another indication of chronicity. And then, of course, if you have seen a renal ultrasound or have ordered one yourself, when we see echogenicity showing diffuse disease and small kidneys, those together mean chronic kidney disease, irreversible. In other words, we're on the path, we can't go back. So that can help pull that together, as some of you will be making the chronic kidney disease diagnosis before you send them to nephrology. So as we close in here, we'll see where we are. We got maybe 3 minutes left if there's any questions. Recapping our learning objectives from both of our sessions here, recognizing the role of obesity in cardiovascular disease and heart failure. We were also looking at least one MOA in GLP-1 and impacts on our cardiovascular disease and on MOAs and SGLT2 inhibitors on heart failure, managing our patients with type 2 diabetes and atherosclerotic cardiovascular disease in our case-based approach, looking at the background classification and statistics on chronic kidney disease, identifying current recommendations on the testing in our type 2 diabetics, evaluating the current base guidelines in the treatment of diabetes and CKD, and then of individual treatment plans and referral options to manage type 2 diabetes.